Hi dear friends, welcome back to the Health Coding Hub. In my last session, we discussed about the E&M documentation guidelines, place of service, type of patient, type of service in the E&M, and introduction about the MDM. Today we will discuss about the MDM based guidelines. In regards to medical decision making, earlier we discussed about the MDM table in brief. Today we will be discussing in detail. So basically MDM is based on three components: number of diagnosis or management options, and the second one is amount and complexity of data to be reviewed, and third one is the risk of complications and or morbidity and mortality. Number and complexity of problems that are addressed at the encounter multiple new or established conditions may be addressed at the same time and may affect MDM. Symptoms may cluster around a specific diagnosis, and each symptom is not necessary at unique condition. Comorbidities and underlying disease in of themselves are not associated in selecting a level of E&M services unless they are addressed, and their presence increase the amount and complexity of data to be reviewed and analyzed, or the risk of complications and the morbidity or mortality of the patient. The final diagnosis for condition does not in and out of the itself determine the complexity or risk, or as an extensive evaluation may be required to reach the conclusion that the sign or symptoms do not represent a highly morbid condition. Therefore, presenting symptoms that are likely to present a highly morbid condition may drive MDM even when the ultimate diagnosis is not highly morbid. The evaluation and our treatment should be consistent with the likely nature of the conditions. Multiple problems of lower severity may in the aggregate create high risk due to the interactions. The term risk as used in this definition relate to the risk from the condition, while the condition risk and the management risk may often correlate. The risk from the condition is distinct from the risk of the management. Definition for the element of management: see the table level of medical decision making. Are problem. A problem is a disease or condition, illness, injuries. In the top of the table you can see the problem address. A problem addressed or managed when it is evaluated or treated at the encounter by the physician or other qualified healthcare professional reporting the service. This includes consideration of further testing or treatment that may not be elected by virtue of risk benefit analysis or of patient, parent, guardian, or the choice. Notations in the patient medical record that another professional is managing the problem without additional assessment or care coordination documented does not qualify as a being addressed or managed by other physician or qualified healthcare professional reporting the service. Referral without evaluation by history, examination, diagnostic studies, or the consideration of the treatment does not qualify as a being addressed or managed by the physician or other qualified healthcare professional reporting the service. For hospital inpatient and observation case services, the problem is the problem status on the date of encounter, which may be significantly different than on admission. It is a problem being managed or co-managed by the reporting physician or other qualified healthcare professional and may not be cause of the admission or the continued length of stay. Now look at the term minimal problem. A problem that may not require the presence of physician or other qualified healthcare professional, but the service is provided under the physicians. Look at the term self-limited or minor or manageable problem. A problem that runs a definite and prescribed course is transient in nature and is not likely to permanently after health status. Look at the term stable chronic illness, a problem with an expected duration of at least 1 year or until the death of the patient. For the purpose of defining chronicity, conditions are treated as a chronic whether or not stage or severity changes. Look at the term acute, direct, or well controlled defined problem, address, or injury. It means a recent or new short term problem with low risk of morbidity for which treatment is considered. There is a little to no risk for mortality with treatment, and full recovery without the function impairment is expected. Or the problem that is normally self limited or minor but it is not resolving consistent with the definite and prescribed course is an acute uncomplicated illness. And the next one is the term one stable acute illness or one acute direct or well defined problem address or injury requiring inpatient or observation admit. So it means a recent or new short term problem with a low risk of morbidity for which treatment is required. There is a little to no risk of mortality with treatment, and full recovery without functional impairment is expected. The treatment required is delivered in a hospital inpatient stable acute illness. A problem is the new or recent for which treatment has been initiated, the patient is improved, and while resolution may not be complete. Now look at the term under moderate, one or chronic complaint that is not stable or noted as a progressing worsening or side effect of treatment. Now look at the term two or more stable chronic problem address. It means that the chronic problem with the expected duration of at least 1 year or until the death of the patient for the purpose of defining chronic conditions are treated as a chronic whether or not stage or severity changes. Example uncontrolled diabetes or single chronic condition or uncontrolled hypertension or controlled hypertension. Stable for the purpose of categorizing medical decision making is defined by specific treatments goal for individual patient. A patient that is not at their treatment goal is not stable. One undiagnosed new problem with uncertain prognosis. A problem in the differential diagnosis that represent a condition likely to result in a high risk. Now look at the term one acute complaint with unanticipated symptoms. It means that an illness that causes systematic symptoms and has a high risk of morbidity without treatment. For systematic general symptoms such as fever, body ache, illness, fatigue, or minor illness that may be treated to alleviate symptoms, shorten the course of illness to prevent complications. See the definition for self-limited or minor or acute uncompleted systematic symptoms may not be general but may be single symptoms. Now look at the term acute complicated injury, an injury which requires treatment that includes evolution of body systems that are not directly part of the injured organ. The injury is extensive or the treatment options are multiple and are associated with the risk of morbidity. Now look in term high level, one or chronic problem severely triggered progression or side effect of treatment. The severe exacerbation or progression of chronic illness or side effect of the treatment that have significant risk of morbidity and may require hospital level of care. And look at the term one or acute chronic illness injury that poses a threat to life or bodily function. It means that an acute illness with systemic and symptoms or acute complicated injury or chronic illness or injury with exacerbation and or progression or side effect of treatment that poses a threat to life or bodily function in the near term without treatment. Examples may include acute myocardial infarction. Now, for selecting the MDM level, we have the second element, the amount and complexity of data to be reviewed and analyzed. These data include medical records, tests, and other information that must be obtained, ordered, reviewed, and analyzed for the encounter. This includes information obtained from multiple sources or the communication that are not reported separately and the interpretation of the tests that are not reported separately. Ordering a test is included in the category of test result and the review of the test result in the part of encounter and not subsequent encounter. Data are divided into three categories: test documents, order, or independent history. Each unique test, order, or document is counted to meet the threshold number. And the second category, independent interpretation of test, not separately reported, discussion of management or test interpretation with external physician or other qualified healthcare professional or appropriate source that should not be reported separately. Let's discuss about these four levels: minimal or none. Basically, it will be the straightforward condition. Minimal infers the typical work of the encounter, but no additional order, review, or otherwise classified work of the provider to be categorized. Limited must meet the requirement of at least one of the two categories, category 1 test and documents. Any combination of two from the following: first, review of prior external notes from each unique source. The second one, review of the result of each unique test. The third one, ordering of each unique test including reviewing result. And the second category is assessment requiring an independent historians. A historian means an individual example parent, guardian, surrogate, spouse, witness who provides a history in addition to history provided by patient who is unable to provide a complete or reliable history, example due to the developmental stage or dementia. Moderate level must meet the requirement of at least one out of three categories below. The category 1 test document or independent historians consist of any combination of three from the following. Refer to example above. Evaluate external record from an external provider may not divided per test per CPT. And the second point is review of prior test result per the unique test, that is per CPT, except test ordered by the rendering provider. Ordering imaging lab and psychometric psychological data testing per CPT. Encounter including an additional historians. And the second category is independent interpretation of test, which include the elements rendering provider document and independent interpretation of test that has been or will be formally read and built by another provider. A formal report is not required of not separately reported. For example, say provider requests a chest X-ray, reviews the image and provide an interpretation within the ENM at the time of service that impact care. Radiology will provide an overread at later time which will be billed. And the third category is discussion of management or test interpretation, which include the elements documentation identifying direct dialogue between the external provider or other appropriate source that is not separately reported. Regarding the management or test interpretation of the patient, examples say provider makes the decision to send the patient to the ED department. The provider calls the ED provider to discuss the issues. And the fourth category of MDM for the amount and complexity of data to be reviewed and analyzed is extensive, which must meet the requirement of at least two of three categories. Category 1, test, document or independent historian. Any combination of three of the following. Evaluate external record from an external provider may not divided per test per CPT. Review of prior test result per unique test, that is per CPT, except test ordered by the rendering provider. And ordering imaging lab psychometric psychological data testing per CPT. And encounter including an additional historian. Or category 2, independent interpretation of test, which includes rendering provider document and independent interpretation of test that has been or will be formally read and billed by another provider. A formal report is not required, not separately reported. And the third category is discussion of management of or test interpretation, which includes documentation identifying direct dialogue between external provider or other appropriate source not separately reportable regarding the management or test interpretation of the patient. Third category of MDM level risk of complication of patient management consists of again the fourth level similar to last two categories like minimal, low, moderate and high. The minimal risk of morbidity from an additional diagnostic testing or the treatment. And the low category or low level consists of risk of morbidity from an additional diagnostic testing or treatment. And the moderate level risk of morbidity from additional diagnostic testing or treatment, for example say prescription drug management. Decision regarding minor surgeries with identified patient or procedure risk factors. Decision regarding elective major surgeries without identified patient or procedure risk factors. And the decision or treatment significantly limited by social determination of health. And the fourth level is high risk of morbidity from additional diagnostic testing or treatment. And the example includes decision regarding elective major surgery with identified patient or procedure risk factors, decision regarding emergency major surgeries, decision regarding hospitalizations, and the decision for the DNR. In the medical decision making levels, remember to qualify for given type of decision making, two of three dimensions must be met or exceeded. Let us the data point table to determine the correct level of MDM required. For example, say look at the below table. Given 4 problem points, 2 data points and moderate risk. Since only 2 or 3 points dimensions are required, this would add up to moderate complexity medical decision making. Let's discuss some medical scenario based on the MDM levels. Level 1 is straightforward. See, look at the below example. A patient C with the stable hypertension, BP is perfectly controlled, no changes are made, and the plan is to follow up in 6 months with labs. Now the calculate the established problem is 1. So our problem diagnosis is 1 point and the data reviewed or order clinical lab test point 1 and the risk of presenting problem is 1 stable chronic illness. So our risk will be leads to low. Using the MDM points table, determine the level of MDM since only 2 of 3 dimensions are required. This would add up to straightforward medical decision making. Now let's discuss the second level of complexity for the MDM. Below here you can see the medical scenario. The same patient returns in the 6-month, BP is well controlled, renal profile is normal, the patient is now complaints of symptoms of URI. Recommendation is for Tylenol and fluids and the plans is to return in 6 months with labs. So here the problem points are self-limited or minor URI symptoms. The total points will be the 1 and the patient is suffering with the established problem that is stable, so the point will be again 1. So for the problem diagnosis total points will be 2 and the data reviewed is 1 lab test, so here the point will be make 1 and the risk for presenting problem 1 stable chronic condition. According to the risk management option, physician here ordering the OTC drug. Now using the MDM points table, determine the level of MDM. Since as per our rule only 2 of 3 dimensions are required, this would add up a low complexity medical decision making. And the third level of MDM is moderate complexity. Here we can see the medical scenario. In the hospital, the physician sees the patient with improving COPD exacerbation. The patient also has hypertension and GAD which is stable. Labs reviewed and RWNL. The physician switched the patient from IV to PO steroids and orders AM labs. Here we have the established problem COPD, GAD, hypertension which all are stable problem. So total points for the problem diagnosis will be 3 and the data reviewed order clinical lab testing point will be 1 and the risk presenting problem here we have 2 or more chronic illness, so it will leads to moderate and according to the management option physician is prescribing drug, so it will leads to the moderate complexity medical decision making. Using the MDM points table, determine the level MDM since as per our rule 2 of 3 dimensions are required. This would add to the moderate complexity medical decision making. And the fourth level of MDM is high complexity. Look at the scenario here. In the emergency room, a 65-year-old patient presents with the sudden onset severe another chest pain. The physician orders lab and checks X-ray and personally review the EKG. The diagnosis is acute MI and the patient is admitted. IV with diuretics and echo are ordered and routine labs including serial cardiac enzymes. So here the patient is suffering with the new problem with additional workup plan and the problem diagnosis should be according to our table is 4 points and the data reviewed order clinical lab test is 1, and the order X-ray point is 1. Again, order medicine test is again 1. Independent review of tracings is point, should be considered as a 2. So here the data review total points will be 5. And according to risk table, the presenting problem is acute or chronic illness, injuries that pose to a threat to life or bodily function will be meeting criteria, high risk. And here again the management option, physician provides IV fluids with additives, so again it will leads to the high risk. If we are using the MDM points table, then we can determine the level of MDM. Since as per our rule only 2 of 3 dimensions are required, this would add up to high complexity medical decision making. Now here we almost finished MDM based guidelines according to 2023 updates. If you have any questions or issue with understanding, please do not hesitate to reach out to me. I am going to drop my email ID in the video description. In forward to next session where we'll be discussing the time-based ENM section and the section-wise guidelines for OP visit, IP visit, observation and consultation with sample medical examples. So dear all, take care. Thank you so much for watching my video. Have a good day.